First of all, I would like to thank the organizing committee for the invitation, and I will speak about the functional mitral regurgitation, the importance of medical treatment, and cardiosynchronization therapy as the first-line therapy. Functional or secondary mitral regurgitation results essentially from left ventricular dysfunction and remodeling, and is a common complication in both ischemic and non-ischemic dilated cardiomyopathy. And the prevalence of functional mitral regurgitation can reach up to 60% in non-ischemic cardiac disease, and is associated with a worse prognosis, with a threefold increased risk of heart failure and a twofold increased risk of death. And actually, the medical treatment and cardiosynchronization therapy are considered as a first-line therapy for functional mitral regurgitation. Just a little overview of the pathophysiology to subsequently understand the importance of the medical treatment and resynchronization therapy. Actually, is considered the functional mitral regurgitation as a more complex pathology, which results from an imbalance of two opposite forces, the tethering forces, which are increasing, whereas the closing force are decreased. And there is this imbalance lead to a reduced leaflet coaptation reverse, and the main determinant of the increase of tethering force is the displacement of the papillary muscle, whereas the main determinant of the decrease of closing force is the reduced left ventricular contraction, and all these abnormalities results from left ventricular remodeling and left ventricular dyssynchrony. This mechanical dyssynchrony is a potential co-determinant for functional mitral regurgitation by several mechanisms. First of all, it increases the tethering forces, but also it decreases the closing forces by the decrease in left ventricular contractility, and can lead to AV dyssynchrony with consequently a diastolic functional mitral regurgitation. From physiopathological mechanism arise the therapeutic concepts, including the use of optimal medical treatment, the cardiac resynchronization, and the mitral valve transcatheter edge-to-edge repair. And it's important to correct to treat correctly and early the functional mitral regurgitation because of its prognostic implications, and several studies have demonstrated a strong association between secondary mitral regurgitation severity and both all-cause mortality and heart failure hospitalization, and the presence of even mild functional mitral regurgitation at discharge was associated with worse outcomes. And the guidelines for the management of valvular heart disease, published in 2021, therapeutic consideration for the management of patients with chronic severe secondary mitral regurgitation and the optimal medical treatment and resynchronization therapy are the most effective therapy. Concerning the medical therapy, the guideline-directed mediated therapy for heart failure is the first-line treatment for patients with functional mitral regurgitation, and it plays a pivotal role in left ventricular reverse remodeling, since studies reported until 50% reduction in grade of functional mitral regurgitation, but this treatment should be optimized as much as possible to reduce the severity of functional mitral regurgitation. And the rationale of medical therapy arise from targeting different aspects of physiopathology, including loading condition, mitral valve leaflets, annular dilatation, dyssynchrony, and heart failure and ischemia. Concerning the use of the ARNI, PROVE-HF, EVALUATE-HF, and a meta-analysis conducted by Wang and al. Have demonstrated that ARNIs are effective for left ventricular reverse remodeling, as evidenced by improvements in left ventricular reverse remodeling biomarkers, with reducing of left ventricular and systolic and diastolic volumes. Moreover, prime trial have concluded that ARNIs also reduced functional mitral regurgitation and are effective for left ventricular reverse remodeling by several physiological pathways. It's already established also that angiotensin-converting enzyme inhibitors and angiotensin receptor blockers reduce or prevent adverse left ventricular remodeling, as demonstrated by SOLVED study and Valashev, which highlighted the important role of respectively enalapril and valsartan to reduce left ventricular remodeling. Beta blockers improve also left ventricular ejection fraction as well as left ventricular reverse remodeling, and the evidence on diminution of ventricular functional mitral regurgitation is robust, particularly for carvedilol, as has been demonstrated in different studies. The use of mineralocorticoid receptor antagonists are also interesting for reduction of functional mitral regurgitation, and there is strong evidence for a positive role of this medication on left ventricular reverse remodeling, as evidenced by improvement of left ventricular ejection fraction, left ventricular ejection stroke, and reduction in left ventricular and diastolic and systolic volume. The SGLT2 inhibitors significantly also improved all the indices of left ventricular remodeling, such left ventricular ejection fraction, left ventricular mass index, particularly in patients with heart failure with reduced ejection fraction, with reduction of left ventricular and diastolic volume, and improvement in left ventricular ejection fraction. But no report yet on the effect of GLT2 directly on all parameters of functional mitral regurgitation. Cardiosynchronization therapy is a well-established treatment for heart failure in selected patients with the proof of left ventricular desynchrony, particularly for the patient who is still symptomatic despite optimal medical treatment, with QRS with more than 150 milliseconds or more than 130 milliseconds with left bundle branch block morphology. And the early beneficial effect is probably from the reduction of functional mitral regurgitation due to improved and coordinated timing of mechanical activation. And the benefit is derived from the left ventricular desynchrony overall improvement. A synchronous and effective left ventricular contraction is achieved, and by minimizing the left ventricular desynchrony, CRT can contrast all the pathophysiologic determinants of functional mitral regurgitation by the following mechanism: by increasing the closing forces, by reducing the tethering forces, by reshaping annular geometry and function, and finally by correcting diastolic mitral regurgitation. But all these effects don't occur at the same time, but one leads to other. And there are two phases of mitral regurgitation after CRT implantation. The first immediate can happen suddenly after the implantation and may be the expression of more coordinated activation and is the major determinant of favorable response to CRT and is a robust prognostic determinant after resynchronization therapy. Whereas the remote phase of reduction of mitral regurgitation, which can happen after several weeks after the implantation, is probably secondary to left ventricular reverse remodeling with reduction in left ventricular dilatation and sphericity. And this is a table which summarizes the different trials which evaluated mitral regurgitation after CRT implantation, and the earliest trials are the Kerashev, Miracle, Mystic, which reported a significant reduction in functional mitral regurgitation severity at 3 and 6 months. These are the main results of Kerashev study, and the conclusion is the mitral regurgitation severity at 3 months was the strongest predictive of mortality. In the Miracle study, the mitral regurgitation decreased significantly at 3 and 6 months in patients with moderate to severe heart failure. And in the Mystic study, mitral regurgitation has decreased markedly by 24% at 6 months and by 45% at 12 months. But in these earliest trials, mitral regurgitation evaluation has many limitations, and the latest study provided a quantitative and more detailed assessment of mitral regurgitation. And the study carried out by Verart have concluded that CRT lead to an immediate sustained reduction in mitral regurgitation measured as vena contracta width, and CRT lead to reverse remodeling at 12-month follow-up with a significant correlation between change in mitral regurgitation severity and left ventricular reverse remodeling. Von Bommel in his study also have concluded that CRT reduced the severity of functional mitral regurgitation at 6 months in all evaluated parameters: vena contracta width, effective regurgitant orifice area, tenting area, systolic pulmonary artery pressure. Improvement in mitral regurgitation after CRT has a prognostic impact, as you can see in this figure, that patients with a mitral regurgitation grade of less than 2 during the first 6 months after CRT had significantly better survival. And in this study also, during long-term follow-up, survival was superior in mitral regurgitation improvers compared to mitral regurgitation non-improvers. And the conclusion is that the mitral regurgitation improvement was showed as an independent prognostic factor for survival. And finally, all this data suggests that it is possible to achieve mitral regurgitation improvement early after CRT implantation, but more commonly after 3 or 6 months, and more often in sinus rhythm patients. But sometimes CRT neither modifies nor worsens mitral regurgitation, and this is associated with unfavorable long-term survival. Unfortunately, in 20% of CRT patients, significant mitral regurgitation persists and are often found to be CRT non-responders because of the extent of the scar and because the fact that left ventricular dyssynchrony is only one component of this complex disease, and CRT alone has some intrinsic limitation for functional mitral regurgitation resolution. In such case, additional device treatment should be considered. And in conclusion, functional mitral regurgitation is not an innocent bystander, but significantly impacts survival. Consequently, functional mitral regurgitation and heart failure should be considered as a unique and complex syndrome. Optimal medical treatment optimization must be the first choice in all patients with functional mitral regurgitation, but in an attempt to achieve targeted dose. And for patients who are refractory to optimal medical treatment, should be evaluated for CRT in selected patients. In case of non-response to CRT, further interventional procedure should be considered, such as mitral valve transcatheter edge-to-edge repair. In this perspective, a heart team should evaluate the best approach, but this evaluation should be done before left ventricular remodeling has progressed too far, and thank you for your attention.